My role now is to continue what has been really a very succinct and useful opening presentations from each of you. So thank you each very, very much. I'm going to just start by asking a question that I think was implicit in each of your presentations, and ask you to comment on, as we think about a framework for developing clinical guidelines, ought they vary by setting? And each of you practice or do research in slightly different settings, and certainly sort of spoke about your own perspective. So maybe we'll start, at least at this round, just sort of in the order that you presented, to comment on that question.
Sure. I believe less important than the setting are some of the other factors that we mentioned, such as the underlying comorbidities and the functional impairment, perhaps the severity of pain. So to me, it doesn't matter if you're treating an apple in the ER or in the outpatient setting, but I would think about it in those other ways.
Yeah, I don't know of much evidence that relates whether you have a continuity relationship with the patient in prescribing of opioids, but I think that would be the biggest difference in settings, that some of us have continuity relationships, but emergency settings don't. But I'm not really aware of evidence that addresses that, but that might be a factor.
So as the emergency physician in this group, I would say I do think that there should be some differences in terms of what's done in the ED setting. But then once a patient, if you have the capability to discharge them from the ED, perhaps the guidelines there with regards to specifically opioid prescribing in the outpatient setting, we should, whatever we do in the ED setting, angle towards that. I think it's important that they be different within the ED setting, because often for us, we'll come at the approach of, well, is this a patient that potentially may need to be admitted or discharged? And if they're going to be admitted, I think that there are differences with regards to what might happen with regards to their care. In many cases, many of our patients will be admitted for surgical reasons, and we'll hear more about that later. But let's go with the example of pancreatitis. These are often patients that have to be admitted if they have a severe pancreatitis, and we're not going to just give them oral opioids for their treatment. They're going to get IV opioids for pain management. And so with that in mind, I do think that there are some differences with regards to our approach.
And let me just follow up before moving on, is just if we just thinking about how Dr. Throckmorton instructed us about really focusing on the outpatient setting, assuming that someone's not going to be admitted, can you just comment a little more on the emergency medicine role and thinking about then which conditions or how the setting influences that decision?
Yeah, I think...
And also in light of what Dr. Brown said about perhaps less likely to have a continuity relationship.
Yeah, I think for those patients that I know that will have good follow-up after I discharge from the ED, because I'll say often we'll work when in the emergency clinician, there is no continuity of care. We're seeing a patient in a cross-section of their care. They're often there because they're at nadir or in extremis in terms of where they might be, whether it be an acute or an acute on chronic condition. But that being said, I think if we are really targeted and we know that this patient is going to be discharged and we know that they're going to have follow-up, an adequate follow-up, that's where we have the opportunity to really help contribute to appropriate outpatient management of opioids. I do want to highlight, I'm going to use this opportunity to point this out. When it comes to opioid prescriptions, emergency clinicians actually contribute quite a small portion to that range. I think a lot of people think, oh, well, the emergency department, that's where a lot of these opioids are being prescribed. We actually represent like less than 5% at this point. Over the last 5 years, we've seen a tremendous decline. Actually, Kit Delgado has highlighted this before, but a tremendous decline in prescribing of opioids from the ED setting. And a lot of this is the broader outpatient office setting. So when we do prescribe, it's going to be a very short course, 3 days. And then at that point, they really need to be making sure they follow up with their outpatient primary care physician or clinician.
And Dr. Bisson, if you could comment just back to the question about setting, and I think what I imagine in your particular setting, working with folks who may had a sports injury or other injury, both in the medical management, of those injuries?
Yeah, once they've been seen by an orthopedic surgeon, they're definitely getting their definitive care for their musculoskeletal injury. So we don't really have the continuity issue, which I can see would be a significant concern. And we're using all of those different modalities. So we're moving in the direction of, I think as a community, using fewer and fewer opioids and using a bunch of the things that we've used for a long time, immobilization, proper splinting, the right types of, say, casts, for instance, or definitive surgical care, as well as physical therapy and aspiration of an acutely effused joint. Those are things that we'll do pretty commonly for people with the different situations that I brought up.
Thanks. So it sounds like what you're saying is when non-opioid strategies are readily available, they are easy to reach for or employ for different conditions. And I think that is also a thread that I heard through the other presentations, and I'm wondering, and I see Dr. Brown nodding, so I'll invite him to comment on clinical guidelines that account or don't account for evidence around non-opioid treatment. How important is that in a clinical guideline?
It's important. The alternatives, but I totally agree with the experts here who've said that what it says in a guideline and what is available in your community are totally different. Many of my patients don't have the ability to go to physical therapy, for example, which is a great example. So yes, I think the relevant non-opioid treatments are really important. And I think a lot of the lack of access, for example, behavioral care, is what has gotten us into this trouble with the opioid epidemic.
Do any of you else want to comment on that? The sort of in thinking about framework for developing clinical guidelines for the common conditions that we're all, or the conditions that you've all named. What is the weight in such a framework of non-opioid effective care?
I think it's critical. I imagine that the bottom line is going to come down to opioids as a later or last resort. So we need to know what the first resort is, and we need to know if we're recommending to hold off on opioids or limit opioids, what is the first line most effective treatment. So personally, I don't see how they could be separated.
So I would concur. I think it's especially critical. So I'm going to, again, come at this from the emergency physician perspective of we've got the timing of everything compressed down. And by the time they're actually in the ED or perhaps in your office, they've probably tried other things. And it's really important to know what they've tried. Were they NSAIDs? Was it acetaminophen? When was their last dose? And at what dose were they taking it? Because if they're taking 800 milligrams of acetaminophen, they've been taking it for the last week every 6 hours, I don't think you're going to want to reach for that again. And especially with older patients, we have to be very concerned about that. But knowing what other therapies they've tried and then when the last dose was and where they are with their pain, that will very much guide, I think, whether or not you would next reach for an opioid.
Yeah, I would agree with that completely. I'm thinking the narrative story, too, of I get back to the continuity issue that Dr. Brown brought up. Which is people change radically after, say, fractures or musculoskeletal injuries within the first 72 hours, 3 to 4 days. They go from being absolutely terrible to really not all that bad. And if you're a primary care physician and you're not seeing them evolve through that, there could be, I think, not necessarily an opportunity, but there could be an occasion for them to prescribe too much opiates. Also, I'm speaking from the perspective of orthopedists being some of the worst offenders if you're looking at overprescribing. I think we're number 4 on the list the last time I looked. So we're all taking this to heart and trying to do everything we can to reduce the number of pills, particularly on the primary prescription.
So backing a step up just for a second, I think in his presentation, Dr. Bisson sort of commented on as we move forward with a framework for clinical guidelines, you mentioned not making such a framework too complex or too many things that will be too hard for clinicians to follow. And so just big question, we asked you each to name specific conditions, and we are following our request from our colleagues at the FDA. And I guess I want to ask each of you point blank, should the guidelines be for specific conditions, and perhaps how specific, or ought they be more generally? And I think also Dr. Starles touched on this, both by diagnosis and by location. So I'd like each of you to respond to that question, general, specific, and perhaps comment on how specific. And I'll start with Dr. Brown, if that's okay.
I think it's lots of times really hard to be specific. I think maybe in an orthopedic sports medicine setting, you might see people with more specific injuries. In primary care, we see a lot of people with non-specific pain, even acute non-specific pain. So for example, and even if you take something which seems simple, like an ankle sprain, there's a huge variety of severity of ankle sprain. And so I think it's going to be really hard for you to say, well, for ankle sprain, opiates should be given for 5 days. And, another common thing we see is someone who had fender bender. Well, they have, neck pain. But there's a huge spectrum of how long that pain lasts. And like I said before, how someone heals from an ankle sprain and the pain from an ankle sprain has a little bit to do with the severity of the ankle sprain, but also has more to do with that person's underlying, often social circumstances.
Again,
I can take that one while we're waiting then.
Sure.
Yeah, and I would agree with that completely. I think it has a lot more to do with external factors than actually the healing of the ankle sprain. Because even the most severe ankle sprains, they're going to be a lot better 3-4 days later if they're properly treated. Ice elevation, a little bit of immobilization, and then some functional rehabilitation. And I realize that that's, talking in sort of a perfect world. But even those measures ought to result in a significant reduction in their pain fairly quickly. And then I start to get concerned about the other situation, which is the person that's in the MVA and they've got cervical pain, and that can last for a long time. And that I start worrying about being one of the situations that could get them chronically on opiates if those are used initially, because that pain can be very difficult to resolve, and they can have that sometimes for months and get into a completely different situation. So just a little bit of a concern there, I guess.
Just to summarize, then I'll turn to Dr. Wang, it sounds like what you're both saying is that clinical guidelines for any given condition need to try to account for severity of the injury or the circumstance. And it also sounds like external factors as far upstream as social determinants of health, but other ones as well, affect the individual's experience of that pain and influence the potential treatment.
Yeah, and if I could just weigh in with one other thing. To me, a lot of it is the time course that you're expecting with the natural history of the disease or the problem. So in musculoskeletal medicine, I and most of my colleagues think of opioids as being for relatively short term. Acute pain that you're expecting to go away, postoperative or from some type of a traumatic injury. So if you expect the natural history of that pain to be high and then go down with time, opioids, you would expect to work for that. But because of the whole tolerance and dependence thing, they become less effective with time. So you're expecting that it doesn't, the way that opioids work wouldn't really match up with the natural history of that. So if you've got a longer acting pain condition like a cervical trauma that's unexplained pain, no real anatomic diagnosis, but just persistent musculoskeletal pain in the spinal region following a motor vehicle accident, I don't have a great ability to predict when that's going to go away, but I know it's going to take a while if it's pretty severe. So I don't know that opioids necessarily match up quite as well with that versus some of these other conditions where we know the natural history better.
So I would concur with the general statements, and so if you were asking if we were to sit more on the general or condition-specific, I would have to say I think the framework again and the approach, which may be general and not condition-specific, is really the more critical aspect, as Dr. Bisson and Dr. Brown mentioned. I do want to caution, and I know that Dr. Throckmorton might not be happy to hear this. If we go along lines specifically of just by condition, the one caveat might be that when we say every sickler, then we should all just, it might be cookbook medicine, and the concern now that we may be too prescriptive with regards to use of opioids or specific conditions, and so that's the one bit of caution I'd have.
I agree, and I want to sort of piggyback on something that Dr. Brown said, which is that in primary care settings, we don't often have the diagnostic or radiologic acumen or results to know exactly what the pathophysiology is. So if you look at the EMR data that I pulled, a lot of the diagnoses were leg pain or knee pain, really nonspecific, and yet the provider was seeing somebody in very severe pain and felt the need to prescribe opioids for them. So I do think to be generalizable in primary care settings, we are gonna, it would be best to have some guidelines focused on broader conditions, the patient with knee pain, for example.
So lack of diagnostic specificity, I guess, in this case.
Yes, although I actually think there might be some specific conditions in addition to general conditions. For example, I hear Dr. Wang's point, and I totally agree about not getting too prescriptive about sickle cell anemia, but it is a unique condition. And so the extent to which we can compile evidence for treating sickle cell crises would be useful as well.
I want to, the next focus, I think we've touched some on this, is how the overall question is how can clinical practice guidelines capture different pain control needs for different populations? We've talked a little bit about specific needs of geriatric populations, I think of sort of athletic-related injuries. I wanted to turn to Dr. Brown as the person who takes care of or has been trained to take care of young people, I guess both of you. And I'm just, if you could comment on what you see as special needs of children and adolescents in thinking through what are sort of the framework to approach the development of clinical guidelines.
I think there is very limited role for opiates for acute pain in pediatric and adolescents. So you might have to at least, what I've seen in a lot of guidelines is they'll have like a special population section, and maybe some of them you would address pediatric or adolescent issues, but I think especially with adolescents, you're going to be extremely cautious with opioids.
And again, to just pick on you, if that's okay, is in the postpartum setting, which may come up in later on in procedural and surgical indications for pain, but in the management, the medical management of conditions following pregnancy, potentially mastitis, or I think you mentioned perineal pain.
Yeah, I mean, I think mastitis is probably a special situation that maybe a week would be useful for opioids. Many of our women with perineal tears go home with a few days of opiates, maybe up to a week. That would be one where I think the natural course would be pretty well understood. And then maybe we're going to hear later about C-section related pain, but I see patients with less than a week of pain from those conditions.
Thanks. Are there other special populations any of you feel that we haven't mentioned where clinical thinking about a framework needs to call out other specific, not diagnostic conditions or painful conditions, but populations that we haven't mentioned?
I'm thinking about two populations. One is patients who are on chronic opioid therapy who have acute flares. Are different because they have often a high tolerance for opioids and maybe different in other ways. And I'm also thinking about patients who have opioid use disorder or addiction who report a lot of discrimination when they, for example, go to the emergency room with acute pain. So thinking about those two populations separately would be helpful.
I agree completely with that. The very challenging patient for us is the chronic opioid user who then has a fracture or something where their pain has to be managed short term, and it can be complex for us to manage their short term pain in the setting of that as their background.
I'll just add that patients that are on long-term medication-assisted therapy with methadone or Suboxone, which of course many more of our patients should be, are another challenge for acute pain conditions.
I agree with that, and I wonder if, given the somewhat unique pharmacologic characteristics of buprenorphine, if there should be specific attention to managing acute pain in patients on buprenorphine.
So that you all raise very interesting questions about sort of the issue around stigma and discrimination, and I think Dr. Lowe and Dr. Throckmorton set us up very nicely to be clear that we want to be sure to deliver adequate pain treatment for these variety of clinical conditions. This is a little bit of a speculative question about how can a framework for developing clinical guidelines be sure not to increase this sort of stigma and discrimination and work towards alleviating it. There may not be an easy answer to this one.
Well, one way might be to specifically address that, for example, people with opioid use disorder can have acute pain and may need to be treated with opioids in certain circumstances, despite the underlying condition of opioid use disorder.
I'm going to comment a little bit about the stigma just from a generational perspective. So I think, of course, I was up here advocating really concern and caution and considerations with older patients. I think for older patients, they do often see use of opioids as a stigma. I think that, again, as I may have implied too, that may be changing. So, but again, just awareness. And I think in this case, it's a lot of education to the patient, but then also to their caregivers about why these medications are being used. All common sense stuff, but I think it's also important to highlight here.
Yeah, the only thing that I would say, again, to sort of expand on that chronic opioid taking patient who then has acute pain is that's really hard for us because if we try to do non-opioid pain management strategies, most of the time they'll tell us, well, that's just not going to work. And we're afraid to give them the doses that they probably need. So we end up referring them back to whoever's managing their pain chronically for the acute portion as well. I don't know if that's the right thing or not, but we're trying to sort of do no harm, but also manage their pain at the same time and basically validate what they have going on.
So more broadly, it sounds like we're also talking about painful conditions where there's an underlying painful condition and then has the potential for an acute flare or a worsening of the condition. And we've talked about sickle cell disease as one example. Are there other examples that the experts feel that we should consider as maybe warrant either special guidance or consider as we develop a framework in addition to sickle cell? And I'll let any of you answer that.
I'm thinking about inflammatory arthritis, like rheumatoid arthritis and some of the less common inflammatory arthritides, where patients may or may not have chronic pain, but do have flares.
I would add to that burns. I think burns, third-degree burns especially, really where you have, if you had a condition where this is really, in some cases indicated, should be on that list.
And I would also basically take care to separate out not just an acute flare-up of a chronic underlying condition, but a new acute problem. So a patient with sickle cell disease that has a proximal humerus fracture, or somebody that's on opioids chronically for low back pain that then breaks their ankle. That's completely separate and I think obvious, but probably should be put in there.
So it sounds like what you are saying is that opioid prescribing might vary in that sort of context where somebody is either on an opioid chronically or has a chronic medical condition, and there's either an acute painful condition or a flare. Just thinking about another issue that I think Dr. Strahls raised is, and somebody else as well, can we call out conditions where opioids are typically prescribed, but perhaps ought not be, again, to make a generalization, and what, thinking again about our task to develop a framework for clinical guidance, what would those conditions be that you might want to name as not typically or ought not involve opioids? And I think Dr. Strahls mentioned specifically headache as one example. So I don't know if you want to comment a little bit more on what you know about the evidence for that or the approach to that, and then see if other people have other comments as well.
And I was specifically speaking about migraines. There are much better treatments for migraines, such as the ergots and others for acute migraines, than opioids. And there's also the concern about medication overuse headache, where acute headaches and acute migraines can turn into more severe syndrome of relapsing headaches, which is patients are at greater risk when they're prescribed opioids for those headaches. So the American Neurologic Association, I believe it is, the American Headache Association, American Academy of Neurology, maybe it was. There are a couple of different professional societies that have put forth guideline statements saying that opioids are not typically indicated in migraines. That's not to say they are never necessary, because I can't imagine situations where they would be necessary, but certainly not first line.
I think it's true for tension and cluster headaches also.
Yeah, I had on my list sort of conditions where opioids were not indicated, included headaches, sciatica. We often see that, sciatica, and then lower back pain. So for both sciatica and lower back pain, most of those, for some patients they may have chronic conditions and may have some flares, they do resolve over time. And so really, we see them quite often in the ED. They're often asking for opioids, but we need to really do our best to, again, educate them and then try to avoid those if possible.
Yeah, there was just an RCT that showed in low back pain that opiates were no better for pain relief and worse for side effects.
Yeah, I would agree with the I guess the panel's consensus or summary of the literature and the evidence that it's should definitely not be a first line treatment for low back pain. There's good evidence that supports that.
And I think relatedly, and I think we're implying it. It sounds like these are conditions for which there isn't evidence about the effectiveness of opioids. You're implying that there may be more harm than benefit. And so my related question is, are there conditions for which we know or would like to know whether misuse following an opioid prescription is more likely? And is it condition specific, or are there other more upstream or concomitant comorbidities that may travel with?
So I think that for older patients, those that have polypharmacy that use alcohol and also may have depression, they may have a greater risk. And so also alluded to with older patients, they may be at greater risk for these conditions as is. But now if you layer on top of that prescribing an opioid, they may have a greater risk of developing subsequent challenges with the medication.
So you're thinking it's not specific to one condition if we're thinking about making a framework for clinical conditions where opioids useful, but rather thinking about other parts of the person's medical or social history.
Yeah, and I agree. And there are opioid misuse tools that we use before we prescribe opioids to patients. And I don't know of any specific literature around which conditions are most at risk for misuse.
That would probably be helpful to have, would be literature on that. I do know we've got some evidence in orthopedic surgery that patients that are taking an opioid for more than 12 weeks after an orthopedic procedure have about a 50% chance of taking it than a year beyond that procedure. So there's a timing factor for sure that's involved, which would make sense. But I don't know if we have good sort of pathology or disease-specific differences in rates of addiction afterwards.
I'm not sure that it matters so much what the condition is for which it's prescribed. Certainly in terms of developing long-term opioid use, the postoperative period, I agree with you, is a big deal, getting people off sooner rather than later. But in terms of which condition would be more likely to be associated with misuse, I'm not sure that we're going to find certainly existing data about that. To me, the amount of leftover medication is probably the bigger indicator of potential for opioid misuse. So some of these self-limited illnesses that we're prescribing 100 days supply of, right, then there's a lot of leftover for people to use in other ways or other people to use.
So last sort of big question from me, and then I'm going to invite the rest of the committee to ask questions for the next 10 or so minutes. If clinical practice guidelines were available in a condition-specific way, and I think a number of you alluded to this, is the evidence, or where is the evidence base sufficient, and are there areas that you want to call out as being insufficient? And I think a number of you have commented on this already, but it'd be good to sort of think about this in one sort of bucket. So I'll let any of you who'd like to start.
I think it's certainly insufficient in sickle cell pain. It is probably sufficient for sciatica and for migraines. I'd be curious to really see an evidence review for kidney stones because I know there's some data that non-steroidal medications are as good as opioids, but I don't know how rigorous that is or if additional work is necessary.
Yeah, I wouldn't add anything to the musculoskeletal conditions that you just mentioned. I do know that arthroplasty surgeons are definitely against their patients getting opioids for acute pain flare-ups because it just makes it more difficult for them to manage postoperatively. But I don't know that there's good evidence. And the other anecdotal thing is, and it might just be because they can get in to see the primary care physicians faster, but it's very, very common that we'll see a patient that needed to see us desperately last week, and they get in to see us this week, and their pain was absolutely life-changing. They couldn't do anything about it, and by the time they see us, they're markedly better. So it's a lot of times those arthritic flare-ups are very, very short-term.
So I think there needs to be additional evidence, which I'm sure as we go through the day thinking about this, but as guidelines or prescriptive guidelines around specific conditions and opioid prescribing are developed, what may be the repercussions of that with regards to how patients and their practices, what they may turn to as alternatives, really understanding you can change and guide in this direction, but then what are the after effects of that, and what are the pros and cons of such a guideline?
So consequences of overly or let's not value it, but very prescriptive guidance could have net harms in addition to benefits or in excess of benefit. And Dr. Brown, did you want to also add?
No, I have nothing to add.
I also think we probably need more evidence for certain arthritic pain flares, including rheumatoid arthritis. Yeah, and another thing that I've been thinking about, I'm not sure where this really fits, but perhaps you can comment on this, is that a lot of times, either post-operatively or in other circumstances where somebody needs to rehabilitate a joint, we think of opioids as being useful for being able to facilitate physical therapy, right? So the real treatment and the first-line treatment might be physical therapy, but if the pain is so severe that they can't do the physical therapy, then is there a role for opioids in that circumstance? Should we be thinking about it that way potentially?
I think a lot of us in musculoskeletal medicine will actually think about it the opposite way, where we worry a little bit about a masking effect. And the goal of physical therapy is to decrease pain, restore function. And the idea that they mask their pain in order to, say, get more motion, they're going to pay the price later on. So if they're going to use any sort of a pain medicine, and most of the time in my own practice, and I know my colleagues will do this as well, is to just advise NSAIDs for after physical therapy rather than before.
Is that including post-operatively?
Yeah, if they're, we've gone to prescribing fewer and fewer narcotic pills as our primary prescription. We've done that in our organization and have done that in Western New York through sort of a summit, we called it. But the idea is to basically their pain is sort of going to go down fairly quickly after surgery and manage that, and we'll start therapy within 5 to 7 days, but are trying to avoid using analgesia in order to facilitate physical therapy.
I think that might be something to address in the guidelines and recommendations, because I think that there is a lot of perhaps confusion. I don't think I'm the only person that's confused about that, because I do think that a lot of people say, well, I need to take my opioids in order to do physical therapy. So if that's actually contraindicated, then that should be made clear, I think, with some review and advice. Yeah,
I guess I wouldn't speak so strongly as to say it's contraindicated, and I wouldn't want anybody to think that I'm speaking for the orthopedists of the world or anything like that. But in my own personal practice, and again, those of my colleagues, we'll sort of do the opposite.
So thank you. Thank you for that exchange. I also learned things. I know that Dr. Throckmorton was eager to speak to us right now, and then I'll turn to the committee members.
No new speech, I promise. Yeah, a couple things, and just comments for you guys to consider. First, the general versus specific discussion was really rich, and it's an important issue for you all. As you think about it, think about how we're going to make use of your recommendation. So we're hoping to use this in as targeted a way as possible. And so while general guidelines or general framework, I think Ula or someone mentioned a sort of general framework, that might be one consideration, but the information we're really going to be looking to make use of is as targeted a way as possible. And whether that's targeted by impact, sheer size of the population, so post abdominal surgery, you'll think of appendectomy or something that's very common, or it's targeted by severity or targeted by in some other way. That's something to think about. The other thing to think about is the numbers of opioids that are used for a particular condition. So we know from the epidemiology of the use of even post-surgical opioids, it varies widely. And some post-surgical conditions, major joint surgeries and things like that have typically gotten larger numbers of opioids than others. So that may be another way to sort of target some of the recommendations. But again, our goal at the end of this is a relatively specific action. In our world, we tend to live in indication-specific areas, and so the more information you can help us with in that regard, that would be great. The second comment I had to do related to your issue about do not use recommendations, and that was that's another conversation, and I'm glad you've brought that out. To the extent you think that there are data, again, with the framework that you're going to either develop or adopt and articulate, and the quality of the evidence that says, here is an area where we do not believe opioids should be used or should be used in very narrow, so, whatever that language is, that would be really valuable for us to understand too. I mean, we think of indications and we think of, at the strongest level, contraindications, and so that kind of framing would be helpful to us, and identifying those things would be really valuable. So thanks.
Thank you for that. That was very helpful. So I want to turn to my fellow committee members and see if there are additional questions. And I don't know everyone's name yet. So just to remind everyone, please say your name and where you're from, and then your question.
Marjorie Meyer, University of Vermont. One of the things I was struck by was for you in the medical setting in terms of post-operative prescribing specifically. I think many surgeons would presume that most of the opioids and refills that they might get would actually come through their office. And I'm wondering if the guidelines should specifically address the issue of multiple prescribers, specifically in the post-operative setting, in terms of the appropriateness of another specialty providing opioids for a very specific surgical intervention.
Joanna, why don't you take that?
Yeah, I think it's obviously ideal if there's one prescriber, and to the extent that that is feasible in a post-operative setting, that should be the goal. I think a lot of times it's the primary care provider who's seeing the patient in follow-up sooner than the surgeon. So if we're seeing the patient a couple weeks post-op or a month, we might be seeing them at a time when they haven't been able to get back to see the surgeon or not again, is one area where that can happen. And another area is something that you alluded to, if the surgeon is worried the patient's on chronic opioid therapy, for example, and they're not sure how much more to give, that kind of situation where they might feel more comfortable having the primary care physician or practitioner manage that, who knows the patient better. So there are a couple of circumstances where it might make sense to do a trade-off, but it should be a warm handoff and a conversation and, co-management.
That's the exact point that I was going to bring up too, and I guess I would be curious as to know how many of those patients that were getting their post-operative medications were ones that were chronically on opioids or had been on opioids prior to the surgery, because that would make sense. And it also seems that there's very much an opportunity for there to be communication between, say, surgeons and primary care physicians about that specific instance, because we're focusing on the world, I think, right now, or we are as musculoskeletal medicine providers, of the opioid naive patient. So we're very comfortable handling them, and we're shrinking down the number of pills that we're prescribing and taking all these initiatives that way. And then we're sort of leaving the ones that are chronically on opioids for you all. And there may be a disconnect between the understanding of how much pain they get following their surgery and sort of what's expected following, say, a hip or a knee arthroplasty versus a arthroscopic rotator cuff repair or a knee arthroscopy. Those will all be quite different.
So we have just about 3 minutes or so and 4 questions from the committee. I think we probably can stretch it to 5. So I'll just go up in order of when I saw your table 10s go up, Dr. Chow. And again, who you are and where you're from.
Thanks. It's Roger Chow from Oregon Health and Science University. Just wanted to follow up on the non-pharmacologic therapies thing, which I think we all think is important. But I think in the context of acute pain, it seems to me to be a challenge to say require somebody, so somebody comes in with a hip fracture or something, are you really saying that use of opioids should be predicated on, wait to see if they respond to NSAIDs? I mean, we're not going to get them into PT right away. I mean, and then even for someone with, say, acute low back pain, where we might not want to use opioids first line, but if somebody has very severe pain and they're severely incapacitated, even if we wanted to get them into behavioral therapy or exercise therapy, it's going to be a delay. It's not going to be, they're not going to get in for 5 or 7 days, or if we can even get them in to CBT or whatever. And I think these really pose some logistical challenges in saying, no opioids unless, somebody has kind of failed all this other stuff first. So just wondering if you guys had thoughts about that and how we can kind of think about some of these challenges, because again, while I think we all agree that non-opioid therapies are important, how it actually works in practice, I think can be quite a challenge.
Yes, I agree. That's a challenge.
Thank you.
So I think you actually, in many ways, made the case for why it may be setting specific, and also can address some of the concerns here, even going back to the question about the multiple prescribers. In the ED setting, we are likely one of the multiple prescribers. Patients are there for the very reason they've tried everything else, or they've tried what their doctors already gave them and it wasn't working. I think it's really important, though, that whatever opportunity there is to coordinate that discussion, the ED is very busy, but when we can and we have that opportunity to make contact with whether it be their orthopedic surgeon for post-operative care, their general surgeon, or their primary care doctor, or their pain medicine doctor, about what we might be layering on for these patients, especially, again, going back to the fact that they may be on many other medications, but they're in the ED because it's an acute on chronic acute condition where other things have not worked.
So we're going to just do one more question, and I saw Dr. Delgado before Dr. Weissman, so the floor is yours, and then we'll stop after this question.
Kit Delgado from Penn. There's approximately half the states in the country have prescribing limits on opioids in terms of days supplied. And I think the charge from the FDA really seems to be focused on, if you're going to write a prescription, how long we should write it so we don't have unused pills. I'd like to hear from you guys what you think a day's supply is, because depending on how you write Percocet, for example, you could write 1 tablet Q6, or you could write 1 to 2 tablets every 4 to 6 hours, and conceivably you could squeeze 84 pills into a 7-day supply. So I think it'd be useful to have some discussion on how we should formalize some practical guidance for prescribers.
And just to say, I think we'll comment on this, but this will not be the last time we talk about this, so.
I think it's a good point that maybe the number of pills is a more useful metric than the day's supply, because you could put 1 pill per day or 6 pills per day, right? So I think that's interesting. I think that's a nice alternative to think about.
Yeah, most of our orthopedic guidelines, that I've seen now have been number of pills as well, in terms of 5 milligram hydrocodone equivalent, something like that.
Yeah, or you could do it as morphine milligram equivalents.
So I'm glad everyone is talking so much, and this has been very productive, and we have a lot more discussion today, which we really look forward to. Thank you, each of you, for your hard work on presentations and conversation. We really appreciate it.